He's got a very impressive record. He is currently the senior advisor of medicine and nephrology. He's working in the most prestigious Army Hospital Research and Referral in New Delhi. I have happened to work with him way back in 2012, 2015 when I was in Base Hospital, Delhi Cant. And that again is one of the apex organizations. So in a span of 10 years, he's been in the best of the hospitals. He's done his MBBS from MRMC Gulbarga, then went on to do his MD in medicine from Command Hospital Air Force Bangalore. And this is DM in nephrology from PGI MER Chandigarh. It's got over 20 publications, and that's actually belying a person who is more focused into patient care than paper writing. Otherwise, if he was actually a bit inclined into paper writing, this figure would have easily been 200. Areas of interest, sadly to say, it's profession, profession, and profession, and the poor guy doesn't give too much time to his family. I know I can talk about that from a personal experience, totally into clinical nephrology and critical nephrology, and has been involved in over 800 renal transplants. That's a very big attribute. Last time when we discussed with the cardiologist, we had got somebody from the proper corporate sector. This time we're getting a clinician from the government sector where money doesn't really become a constraint when it comes to managing the patient. Along with me, I would also be having Dr. Kinjalkar Ghosh to help me out with the session. Dr. Kinjalkar Ghosh is a professor in the Department of Biochemistry, Tata Memorial Hospital, Parel, Mumbai. Did his MD in biochemistry from Indira Gandhi Government Medical College, Nagpur. Has done his DNB and currently working with more than 11 years experience in clinical biochemistry labs. Is trained in internal audit in ISO 15189 and 2022. That's the latest one, with a number of publications. Dr. Kinjalkar has expressed his slight regrets that currently he's not available on the stage. Should be reaching us in 5 minutes because he's caught in a traffic jam. Notwithstanding, we shall get into the session right now. Dr. Srinivas, just before we started off this series on nephrology, I posted a poll question to all the people in my biochemistry group. Which is the group of clinicians who actually bug you the most? And guess who came top of the list? Okay. The
Obviously,
close second were the pediatricians. But there is a pessimistic way of looking at it that these guys trouble us a lot. There's a more optimistic way of looking at it that these are the guys who are actually dependent upon our results for patient management. So actually, when such a thing happens, we feel quite happy with it. So that's the preamble to start. Uh, Renal diseases is quite a bit common right now. Two terms, AKI and CKD. How do you clinically differentiate it? Because from the lab, we've just got a creatinine value and we see a creatinine value of 2.5. So what constitutes acute kidney injury and what constitutes chronic kidney disease?
okay. So thank you for the kind words. And because as you told, the two clinicians who bugs biochemists the most, pediatrician and nephrologist, because both specialties, time is at premium for patient.
Good.
That's the reason why we are so dependent on biochemist, because more accurate, more easier to decide on the management line. So given that, obviously, so we are heavily dependent on biochemistry to decide our management on day-to-day basis. Let it be critical care, let it be post-transplant or dialysis patients. So that's how it starts. So coming back to the question you asked, how do we say it's a AKI in a, if we can understand the estimated CKD population is approximately 8 to 10%. So even though all are not diagnosed, fine. So it's a huge number. So majority goes unnoticed, as you know, till GFR falls below significant level, creatinine doesn't rise at all. That
But
also. So if that is the baseline, then we can understand how we approach a AKI or a CKD. If a patient comes with a single report of raised creatinine,
yeah,
it is the clinical history, clinical examination, and a given biochemistry. If a baseline is not there, very difficult to decide. Then the trend, along with other laboratory findings, will decide it as a acute kidney injury, or it's a CKD, or it's a AKI progressing towards CKD. That part is called as, in the latest literature, acute kidney disease.
Okay. So
So all three situations are important: clinical findings, clinical history, clinical findings, and then laboratory findings, along with imaging.
So kind of what I understand is that if you had a baseline and the value is baseline value is high and the present value is high, then you'll think more in terms of a chronic kidney disease. And if the previous was good, all right, and the present is high, then you may think it's an acute insult, right?
Yeah.
And the time frame is something like how much? 1 month, 3 months, 6 months? What's the time frame that you generally use?
So the worldwide recognized definition, anybody having a more than 3 months rise in creatinine or a loss of GFR, we call
Mhm.
them CKD, whatever the reasons may be. So
Okay.
given that, so we are left with two situations now. Somebody has
Mm-hmm.
got a normal baseline within 3 months, now comes with a creatinine which is raised.
Mm-hmm.
So he can be AKI, acute kidney disease,
Mm-hmm.
or he may be acute on CKD.
Acute on CKD. Yeah, that's an
Yeah.
interesting term.
Yeah. The second scenario will be somebody has got a raised creatinine 3 months back,
Hmm.
but there is a now significant jump in creatinine.
Hmm.
So now still we are left with two. One is a natural progression of CKD, acute on CKD.
Acute on CKD again. Yeah.
So we have got overlapping areas. So
Okay.
these are the areas where biochemists actually help us to decide in a significant way the management of the patients.
Okay. Can you elaborate a little bit on that? It's very exciting to sound that you really require our help. So can you just elaborate a bit on that?
Just imagine if the lab variation of the creatinine is too much,
Hmm.
where my first definition of AK goes rise in zero point 0.3 milligram per deciliter.
Hmm.
So straight away, I say it's an AKI.
Hello?
Yeah, can you hear me, sir?
Yeah, yeah, yeah. I can hear you. We lost a bit. Yeah,
So
tell me.
the stage one AKI, as per the latest guidelines, is
Hmm.
rise in creatinine by zero point 0.3.
Point 3. Very good.
So if just imagine if lab variation is too high, where I will end up? I will straight away diagnose somebody as AKI.
Okay. No, but
So the
one, one thing which I would like to mention over here is that the labs actually work on very narrow margins. And if you are working in a decent lab, okay, a decent specialist, an NABL logo, I think the results will be quite reproducible. Seriously.
I,
Hello?
I agree with you in that aspect. Variation is another issue. So variation is another issue.
Hmm.
So in that situation, the decision has to be on a trend rather than a single value.
Okay, so trend values tend to become more important. See, there are a lot of these
Yeah.
interesting biomarkers which have come, and we read a lot of literature on it. We see a lot of publications going on it. Cystatin C, challenging the replacement of creatinine. Creatinine has stood the test of time for such a long time. What about these what are these newer markers? I won't use the word better. That's what you're going to tell me. Newer markers in terms of cystatin C, NGAL, TIM, all that. Where do these actually figure out
Okay.
in the role of patient
So,
management?
so if you, I think majority are the persons who know the molecular values and the way it is excreted in the body. So the difference between cystatin and creatinine is mainly the way it is handled by the kidney.
Correct.
Cystatin C exclusively excreted by the glomes,
Hmm.
but creatinine can be secreted
Secreted.
by the tubular cells.
Yeah, that becomes more important when you're going towards the CKD stage, the stage 4, stage 5, where the secretion component becomes significantly more.
Yeah, so anywhere between 5 to 10% the secretion component.
Yeah.
So now cystatin C has got a
Hmm.
molecular weight 1/10 of this creatinine.
Hmm.
And as I told, majority of the CKDs usually
Hmm.
get diagnosed when actually creatinine raised by the time significant GFR is already lost.
Correct.
So majority of the equations which is given as the GFR so-called, they are
Hmm.
all tested in different scenarios and extrapolated.
Mm-hmm.
None of them actually validated on a normal population because the GFR variation depends on so many factors in the normal population without any kidney disease.
Okay.
So, given that scenario, cystatin C replacing creatinine, at least
Hmm.
for next decade, I am not seeing it
What about NGAL as a good marker
because
for AKI?
NGAL, I think when before I started my DM, it was on the main page, front page. It's still on the front page, but without producing much of the results. So the problem is NGAL will tell you ki it's an AKI or no. That's right.
Hmm.
So in AKI,
Hmm.
so if I use clinical scenario, that means clinical history as well as the clinical finding along with creatinine
Hmm.
and urine output.
Hmm.
Actually, definitely I can do an intervention without an NGAL.
Tell me one thing. I just want to understand this concept. Let's there's a vicious cycle going around. The vicious cycle like this. You don't ask me the test, so I don't do the test. I don't do the test, so you don't ask me the test. And this vicious cycle goes. So these markers have really not come very much into the world of medicine. Supposing I take financial constraints out, would it be more effective to titrate the management of an AKI based on NGAL vis-a-vis creatinine? Will there be any difference in that?
So as you understand, biomarkers are not actually the direct measurement of the GFR. You know that.
Hmm.
They only tell me there's an injury or no. That's it.
Hmm.
Because what the naturally happening, like they're excreting, getting absorbed, that has
Hmm.
been disrupted by the pathological process of AKI. So you
Hmm.
are finding it raised. That's all they
Hmm.
are telling you. So they are not going to give you the estimation of GFR.
Right.
They are not going to tell you what will be the reserve of the given patient.
Hmm.
So, and it's very difficult, especially to differentiate the amount of injury with these uh, biomarkers because they are not standardized to the level of injuries, which is more standardized with urine output as well as serum creatinine and the clinical condition.
So at any given date, whatever, once you made the diagnosis of AKI, then the urine output of the patient and the creatinine serial monitoring would be a better marker that these are not actually adding much value to treatment. That's what I get to understand.
Yeah,
Even when finance is not a constraint, because common sectors usually finance is not a constraint.
at least
Procurement is a
in my
constraint.
organization, finance is not a constraint.
Huh?
At least in my organization, there is no
Yeah.
financial constraint.
So that's why your word becomes very more all the more important because every other day you get the pharma guys pushing you for these tests and you get some of the clinicians also saying, why don't you put this? So actually wanted to understand it from the proper clinical perspective that it's not adding too much value to your patient management. Sounds exotic, doesn't add value. That's what is your one line word.
Yeah, 100%.
Oh my God. Right. Then the major thing comes down to this thing. We talk about protein creatinine ratio. What is the role of protein creatinine ratio in the patient management? Now, I know about albumin creatinine ratio and normalizing to creatinine. That's good. Protein creatinine ratio, how is that? And would you want a protein creatinine ratio or an albumin creatinine ratio? What would you be happy with?
So majority data which is available to us is on proteinuria.
Yeah.
And the major albuminuria data is available from the diabetic population.
Okay.
So we use creatinine ratio to say if this sample is sufficient or not in a spot sample to just like normalizing or standardizing the value of proteinuria at the given point of time.
Correct.
Expecting key patient has got a muscle mass producing so much of creatinine a day and this much creatinine will be excreted.
Mm-hmm.
So depending on that, you say, ki, okay, this is at least near the actual representative volume value of a 24 hours urine creatinine protein or a albumin excretion. That is the reason why you use a ratio. Otherwise, as we know, protein is that includes albumin. Other than that, other proteins which is secreted in the urine, or in some pathologies, filtered out in the glomerulus also. So whole protein, yes, non-diabetic kidney disease, you rely more on a proteinuria rather than purely albuminuria.
Okay, but in a
But
diabetic,
in diabetics, albuminuria actually gives you almost near correlation to the actual proteinuria, because there's no much extra proteins which are coming out along with albumin. So that's why in a specific group of diabetics, okay, albumin creatinine ratio is sufficient, but protein creatinine ratio is in other kidney disease. So if you
non-diabetic.
don't have albumin creatinine ratio, then you can still depend on protein creatinine ratio in diabetics also.
If I were to understand what you're saying, if my primary pathology is glomerulonephritis, then a protein creatinine ratio would be good. But if I'm specifically trying to titrate a diabetics and see his kidney state, then an albumin creatinine ratio would be the test that you would order. Do I understand that correctly?
Rather than other way, the data is on albumin creatinine ratio, thinking diabetics have a glomerulopathy causing a proteinuria. So
Okay.
previously we thought ki diabetic kidney disease, glomerular disease. But now gradually we understood that diabetes not only affects the glomerulus, it can be interstitium also.
Hmm.
So still albuminuria control in a diabetic is the standard of care. So you only assess albumin creatinine ratio. So rather than asking patient for doing the 24 hours urinary volume or anything, because diabetics are the ones who frequently go for urine test compared
Hmm.
to other glomerular disease once we do the baseline.
See, there was this line which I've read in my textbook, and I'm not very sure about it, that if you detect a microalbuminuria, the person is anyway going to progress irrespective of whatever kind of treatment you initiate. Or does that give you a window of 5 years where if you intervene, then the disease doesn't progress? How is that?
The problem with diabetics or any glomerular disease is if you can catch them early.
Okay.
So then all interventions, everything may give you a good result in reducing or slowing the pace of worsening of the disease.
So microalbuminuria means the disease has progressed, or microalbuminuria means that it's an early stage. What does it mean?
See, microalbuminuria, as you know, it's a misnomer.
Albuminuria is the correct word.
Correct. So anything which is normal, there's less than 30 milligram per gram.
Hmm.
Fine. So then I take it as a not yet affected kidney as far as the
Okay.
glomerulus goes. So
Right.
now anything beyond 30 is abnormal. Fine.
Ah, our star batsman has also come. Dr. Kinjalkar Ghosh has also come. Nice to see you.
Hello, nice to see you, sir. Hello.
Okay, so I've got him also in the spotlight. Very good. I was fielding a lot of questions and I was not quite sure about it till it gives me a great relief that you've come over here. Right. So we were discussing about microalbuminuria. We were discussing about diabetic nephropathy and whether microalbuminuria is catching the disease early or the disease has already progressed. So what is your opinion on that? Srinivas, Dr. Srinivas.
Okay. So as we know, less than 30, we consider it's normal. Now more than 30. So
Hmm.
that is the stage when it's more than 300 or less than 300.
Right.
That's the point. So with introduction of a new medicines like SGLT2 inhibitors and the world king of diabetic nephropathy treatment, that's ACE and ARBs,
Hmm.
along with mineralocorticoid receptors antagonists. Fine. Then
Hmm.
GLP-1. So we say now 4 pillars of diabetic nephropathy treatment. Fine. So in among them, uh, if you can reduce proteinuria by these drugs,
Hmm.
they do. Practically, they do in the nature.
Hmm.
So if they do it, so that means you can prevent or slow down the disease process. That's the first thing.
Okay.
So that gives you advantage in the sense, first thing is renal function is preserved for a longer duration. Dialysis
Okay.
is postponed, and
Hmm.
patient may not require in their lifetime dialysis if they can preserve their GFR to a good extent. So these are the advantages of picking up early.
Okay.
So
So when you
picking up early means what? So that requires a close follow-up,
Mhm.
and without a good biochemist, you cannot do it. That you know it.
Now, tell me one thing. When you talk about microalbuminuria, our book said 2 out of 3 reports in 6 months is considered as positive. But I don't think I get repeat samples or correlation with previous values. So, do you use this 2 out of 3, or you just take the first value and manage?
If somebody comes with a given history, background history, and before I ask for an investigation, I already know that this is the probably coming going to be a positive test, or this is the highly likely scenario, and test confirms that. I need not to harass my patient by asking for 2 more samples. But
Hmm.
somebody comes with a normal history, there is nothing, comes for a checkup, and I find an albuminuria, which is not alarming, which
Hmm.
is there.
Hmm.
So then I need to test more to confirm because everything lead to intervention. So intervention has to be therapeutic goal, has to have a therapeutic goal or a diagnostic goal. Here, first of all, I have to achieve a diagnostic goal in a normal healthy adult. Then I get 3 samples. But if my probability of before ordering the test that I'm going to get this, I will not ask for the second or third sample.
Okay. So, if on the initial presentation there is microalbuminuria and you have enough reasons to believe that he's a diabetic, uncontrolled and all, you would say, okay, this is positive, I'm managing him to prevent kidney damage. But if the person doesn't have any genuine reasons to have proteins and you're still getting a microalbumin positive, so that's the time when you may give the second and the third sample. Do I understand that right?
Bilkul, sir. That's the right way.
Okay. Now here comes another complicated question. Urine analysis, if the proteinuria by dipstick method is 1 plus 2 plus, then possibly it doesn't make sense doing microalbuminuria test at this time, does it?
It can, sir.
No, I didn't understand
So,
that.
like 1 plus 2 plus is a range it is giving you. Fine.
Yeah, yeah,
So now if albuminuria is more than two-thirds of that proteinuria, so it
okay.
can anywhere between 30 to 300. It gives you that intervention window where you can actually halt the disease process or at least partially reverse it.
Now, how would you be sure that this is a microalbuminuria component or this is not a urinary tract infection component or some other kind of a proteinuria? That doesn't make a difference.
It makes a difference. That's why I told the clinical scenario and the clinical examination findings and with imaging. They're all important in interpreting a given patient's data. Nothing should be isolated, interpreted in isolation. That is like treating the data rather than the patient.
Okay. And this guy's a chip of the old block. He treats the patient and quite an endangered species, I should say, compared to the number of people that I've met. Okay. The question which I was eagerly waiting for Dr. Kinjalkar to come here is, first, I would like to know from your point of view, if you get a report of potassium, let us say 7.5, 7.6, then what do you actually do for validating the report?
Yeah. So we do get such values quite frequently on a daily basis. And obviously, I'm not going to the standard checks that are there where you check your QC and all those things. You try to look at the pre-analytical steps. So it is basically we rule out, sir. We rule out one by one if it is basic, if there is any potential reason by which we can ascribe the increase in potassium levels. So you have the standard ones where if there is hemolysis, it is obvious. Is it slightly hemolyzed? Is it grossly hemolyzed? There are instruments which can give you things like HIL index are there, which can tell you how much hemolysis is there.
Yeah,
Then we
that way, I would say one thing good about the Vitros analyzer, for every sample, it does the HIT. Rest all in the other
right.
liquid chemistry, you have to activate the HIT index for the samples. Vitros by default, HIT is done for every sample. So that's actually one of the good things about the
Yeah.
Vitros.
Absolutely, sir. Absolutely. So here the critical thing is if you need access to the clinical situation. So I am fortunate that way in Tata we have access to the records where we can
Good.
see and also delta check. If it's an inpatient and you can see that this is the second time the potassium level has been sent, or if there is a previous value which is also raised, so okay, this is in line with the treatment that is going on. If you have a abrupt increase, this is the first time an OPD patient, um, So what we try to rule out is it a true case of hyperkalemia or is it a pseudo hyperkalemia? Now, in our hospital, it is very common to find a lot of cases of pseudo hyperkalemia.
Yeah,
And
CMS cases will hit off the roof.
absolutely, absolutely, sir. So the thing is, like when we say hemolysis, the concept is the intracellular potassium is coming out, and
Hmm.
it is increasing the potassium levels. So hemolysis is very obvious to detect, but when you are looking at, say, something where you have CML, you have hundreds and 100,000 WBCs, they are fragile, and you're looking at serum, and when you're centrifuging them, they are going to rupture, and there is no physical way you can detect that there is a rupture of the WBCs that are there. So if the clinician says, okay, your potassium values are abnormal, it is looking weird, and clinically the patient is not showing of elevated potassium, then obviously how do you confirm? So our traditional wet chemistry methods have indirect ICs. Your the dry chemistry one has a direct IC. Your ABG instruments have direct ICs, and you can also change the matrix. Like we you can I mean, many hospitals look at serum, some hospitals may be looking at heparinized plasma. So the thing is, the chances of a WBC getting ruptured in plasma is far less than it getting ruptured when you are centrifuging
Serum.
it in serum.
Yeah.
So we ask for a repeat sample in a lithium heparin tube, and we repeat the electrolytes. We know there are going to be differences in the matrices. So if there is a more than 10% difference in the repeat value from the serum value, then we can say it is a case of pseudo hyperkalemia. So all this is done in a sequential manner. You do delta checks, you see if it is collected in the correct tube, if there is any history. And so that way we are a bit fortunate, sir. We have access to these things. Otherwise, it becomes very
Privileged,
difficult.
privileged people, privileged people.
Thank you,
Acha-
sir.
Dr. Srinivas, I have this question because what he's saying is a thing which I do in the lab before I release a report. Now, here's a typical situation, and there's a very uh, defensive comment I also tend to put on it, kindly correlate clinically. Okay, so here's a patient whose previous value of potassium was something like 5.2. Now I get a value of 6.3. Okay. And I don't find the sample hemolyzed. So I put a comment, kindly correlate clinically and release the report. So at your end, what would you do to evaluate whether this is not consistent with the patient or this could be consistent with the patient? How do you make that decision?
So if again, it depends on is the first time it's happening in the sense the potassium is rising or
Hmm.
patient has got a tendency to have repeatedly raised potassiums. It may not
Oh,
be such a jump. So if somebody's baseline is around 5 and repeatedly they come in between 5.5, 5.7 and you counsel them on readjust the medicine, hydration, everything, and they come back with the potassium report again towards the baseline. These
hmm.
are the patients tend to have this jump whenever there's a increase in potassium intake in a gulp, or there is a change in medications which can alter the potassium metabolism. So these if you can get it out of the history, then you are sure, okay, this is a reliable report, so you should act on it. If none of them are there, so some healthy individual comes to me without any other signs and you give me a potassium of 6, then first thing I will do is check for any emergencies which are clinically glaring at me. In the sense, bradycardia or clinical symptoms suggestive of hyperkalemia and ECG. If they are not there, I
ECG.
got 2 to 4 hours with me.
Okay. If there is no ECG changes and you get a hyperkalemia, you still have a 2 to 4 hours window with you. That's what I understand.
Yeah, I can reorder and get the test done and reconfirm it. And if I got a facility to do a ABG or a VBG, I will do it and reconfirm it. So even though the variation will be there, but at least I know patient is in the safe zone. So I will get a window to act. So his aim is to see that with minimum intervention, patient remains in the safety zone.
Okay. So now this gets to the second question. What I understood from this is that when I release a report, I know that numerically this report is correct, but I don't have enough of information. Dr. Kinjalkar is privileged to get patient access information. Most of us don't have it. So we just validate a report based on our hunch that, okay, all the other things are all right. I have noticed a variation, so I say kindly correlate clinically and I send it out to you. So then your point is, even if the value is high, but if you don't have any clinical signs to go with it, you have a window of 4 hours where the
Yeah,
sample can be repeated. But if my value was high and there was some other things which is pertaining to the patient, then you would intervene. That's what I get to understand.
correct.
Great. So that is one. Now the next question is two groups of patients, and what is the three groups of patients? I'll say hypokalemia, hyperkalemia, hyponatremia, hypernatremia. How do you treat, and more than the treatment part of it, what is the frequency in which you would be wanting to monitor the patient, and what is a response that you would consider adequate?
So we start with potassium because that's the boss.
That's the bus. Yeah.
So potassium, low potassium is more dangerous compared to high potassium.
That is news. I always thought high potassium killed.
Body has got a reserve to readjust,
Okay.
but low potassium body has already exhausted its
Already
reserve. That's the
exhausted its
difference.
stores. It is serum potassium is maintained at the cost of intracellular potassium.
Intracellular potassium.
Yeah.
So now the system which is running on transmembrane potential and other things are at risk, which
Mhm.
will not be ready to respond even if I treat them.
Okay. This is an angle which I didn't think about. Good.
So whenever there's a hypokalemia, I'm more worried. If I am unable to find a source from which patient has lost so much of potassium.
Okay.
As you know, potassium is the most abundant cation.
Right.
So means if somebody has got a low serum value, that means the intracellular
It's
source has
depleted.
been lost.
Correct.
That's why the patient is presenting you with hypokalemia.
Can I just pause 1 second over here? This is for all the youngsters who are there in the group. The word that Dr. Srinivas said is something which we should all kind of infuse in ourselves. The extracellular potassium is maintained at the cost of intracellular potassium. So even if the potassium is normal, the patient could have lost significant amount of potassium. If the potassium comes down, then there's massive stores depletion. This is a point I want all the youngsters to take it. Yeah, Srinivas, you can carry on.
So my response to hypokalemia will be much more faster,
Mhm.
and I would like to replenish the potassium store as soon as possible.
Okay.
So now, as we know, the problem is not the normal person's potassium replacement who is having a functional kidney. I replenish. If there is excess, kidney will take care of it.
Okay.
Problem is AKI and CKD patients where their ability to restore the homeostasis is not good because kidney is not functioning fully. So that's the time
Right.
you require a monitoring.
Okay.
So whenever I'm replenishing, depending on the clinical scenario, so I would be monitoring the potassium value 6 hourly to 12 hourly.
6 hourly, you're not coming to 2 hours, 4 hours.
Even if you do, you cannot change intracellular replenishment in 2 hours. It will take time. It has to
Okay.
shift. The equilibrium has to be established. It will take time. So even if I do a 2 hours, if I react, it may be overcorrection or undercorrection.
Okay.
So we need to give time. So
Mm-hmm.
that's why if you see the potassium supplementation is spread over 24 hours. It's never in a bolus
Right.
because body cannot handle it in bolus. You have to spread it over a period of time. So gradually, wherever the reserves required, it will replenish. At the same
Okay.
time, if there's a loss, it will be ongoing. So at the end of the 6 hours or 12 hours, you know how much more you require to replenish. So
Okay.
in a given scenario of AK and CKD, you have to monitor this because hyperkalemia again has got a requirement of intervention. So rather than actually creating an intervention because of iatrogenic reasons, better to monitor them.
So you would say monitoring of about
So in a
yeah.
hypokalemia, replenishment, monitoring, and preventing iatrogenic hyperkalemia. These three aspects has to be kept in mind.
Okay. So your monitoring frequency is going to be 8 hours or 12 hours?
It depends how much I am replenishing. If a
Okay.
patient comes to me with a potassium of less than 2.5, which is going to be very bad because they are prone for all type of arrhythmias.
We get it very commonly in the lab. Yeah.
So that is the time when you are replenishing. You'll be replenishing in a full or you can say 120 milliequivalent per in a 24 hours period.
Mm-hmm.
Means every hour you are replenishing approximately 50 milliequivalent.
Mm-hmm.
So then I would go for 6 hourly monitoring initially. Once I think the rise over 6 hours is sufficient enough to assure me that I will get a desired value by next 24 to 48 hours, I'll go by 12 hourly monitoring. If the replenishment is insufficient, then again I'll continue to monitor 6 hourly so that I can upgrade my replenishment.
So if your person has started with 2.2, when do you start
Okay.
switching off from 6 hours to 12 hours? At what level? At 3.5?
See, I expect means my safe range starts from 3.5. Fine.
So
So
till
in 24
3.
hours, I want to bring to that lower limit of safety range.
Okay. So from 2.2 to 3.5, preferably every 6 hours, so that you allow the things to equilibrate. And once you've reached the 3.5, then you go slowly over a period of time, and that time the switching changes over to 12 hours. That's what I kind of understand.
Yeah. Once I cross 4, I would stop actually replenishment.
Okay. Okay, that's interesting, because sometimes I see the from 2.5 to 6 and then coming back down. I see that pendulum swing many a times. So this is quite
That,
interesting.
that is because if I take a sample while replenishing from the same arm, that's one thing. Second thing, my replenishment duration has been shortened. Rather than spreading it over 24 hours, I given it over 6 hours or 4 hours. So now obviously, we tend to land up with a hyperkalemia.
Okay, that's a transient hyperkalemia. Over a period of time, the body will redistribute it. So you're actually not dealing with hyperkalemia, but the numerical values suggest hyperkalemia.
Yeah.
Okay, this is interesting. What about sodium?
Sodium reserves are very good in the body compared to potassium because sodium is not involved that way. So the major reserve, as you know, is the bone.
Hmm.
So if somebody has got a healthy bone, you tend to have good sodium reserve, at least in the acute phase. Right? So somebody is chronically hyponatremic. These are the patients actually is a problem.
Hmm.
So in that scenario, actually, I'm more worried about hypernatremia rather than a hyponatremia without a symptom.
Okay, let's understand this. In potassium, you're more bothered about the hypokalemia, and in sodium, you're bothered about the hypernatremia.
Yes. So
Okay.
because whenever yes, if sodium crosses 155,
Hmm.
the changes which happens at a cellular level and CNS changes, which are very difficult to handle actually.
Okay.
And you require a larger volume redistribution to readjust them.
Dialysis is not a solution.
Dialysis, then you have to depend on a long dialysis because dialysis you do only for 4 hours.
Okay.
So you cannot change the changes within the brain in 4 hours
Right.
because of the blood-brain barrier and the other constraints. So you cannot suddenly change the whatever the changes happen in the brain suddenly. That's why even though the latest concept of treating the sodium issues are much changed compared to what it was last decade. But still, the basic concept remains same. It's not easy to change suddenly the sodium associated problem in the CNS.
Right.
And asymptomatic hypernatremia, I'm more worried about the cellular level changes in the enzymes and the other aspects rather than actually the symptoms. So those, if they are gone, so most probably kidney also will not be able to help the patient to restore to the normal sodium homeostasis.
Hmm.
So that's why in sodium, I'm more worried about asymptomatic hypernatremia rather than a asymptomatic hyponatremia.
What about a symptomatic hyponatremia? Like I'm going to give my
Symptomatic
father's,
hyponatremia, it's an semi-emergency. You have to deal with it as an emergency only.
but
Because you have,
the levels of the CNS symptoms, I mean the CNS symptoms, I don't think correlate very well with the serum sodium levels, do they?
they don't. That's why I'm telling you. Asymptomatic hyponatremia, I'm actually keep it lesser than asymptomatic hypernatremia. But symptomatic hyponatremia, I will treat it as an emergency.
Irrespective of the sodium levels.
Yeah, obviously.
Okay, now that's a very interesting thing because I mean, giving a personal example, my father was hallucinating when his sodium was 132, and people said, "This is quite normal. What's the problem?" But he was frankly hallucinating.
So actually, that's a fact because we don't know what is the status at the CNS level for the sodium homeostasis. We don't know. So what was the baseline homeostasis for a given person is very difficult to assess actually. So that's why I say treat patient, not the data. So you may again say,
You know what I'll say. Okay, so the whole concept about electrolytes, what I understand as of now is that hypokalemia is very serious and hypernatremia is very serious. Hypokalemia, treat aggressively, monitor every 6 hours until it reaches a 3.5, and then stop the treatment when it's reaching 4 and observe. That's what I've kind of understood. And hypernatremia, you have to
so we
treat.
are left with hyperkalemia.
We'll have to
Yeah,
hyperkalemia. Yeah.
sorry, hypernatremia. Obviously, I would like to treat. The commonest way we treat is give a sodium-free fluids. It
Fluids.
can be oral or IV. So
Okay.
then you replace gradually and redilute and redistribute. So when it
O-
fails, you may use dialysis, but that's not the recommended treatment
Okay. So the treatment for
for
hypernatremia would
hypernatremia.
be sodium poor fluid, either orally or IV. Right. So then we missed the hyperkalemia
Yeah.
part.
So then we left with hyperkalemia.
Insulin glucose.
We are left with yeah. So that again depends on what we are dealing with. Hyperkalemia, which is acute or a chronic one, with a
Mm-hmm.
ECG change, without a ECG change. With
Mm-hmm.
the ECG change, it has to be treated like an emergency.
Mm-hmm.
So the easiest or the fastest one to act is the beta stimulants,
Okay.
which gives you the shortest action. Means in the fastest way, it will give you the shortest period of action you use, but it's a larger dose of beta to stimulant nebulize. So
Mm-hmm.
first you shift the potassium intracellularly
Okay.
with the beta stimulant. Then you use insulin, and to protect on insulin, you give dextrose to prevent
Okay.
hypoglycemia. Again, intracellular shift.
Okay.
So, but if there is ECG change, you require a membrane stabilizing agent, that is calcium,
Okay.
to prevent an arrhythmia till you intervene.
No, so we'll first give the calcium and then
So, if
you start.
somebody doesn't, that is with ECG change.
Okay, for hypernatremia, hyperkalemia with ECG changes, first you start off with calcium and then you start off with the beta stimulants
And insulin,
and
uh,
glucose.
so insulin is supposed to be given in a short period,
Okay.
not supposed to be given over a long period. Fine, we cannot actually, ideally, you have to give bolus, but it's not easy to give bolus. So, what you do is you short infusion period. So, give them in a short infusion period. So, after that, obviously, you have to reassess the patient for changes. If you are given adequate anti-hyperkalic measures, so then ECG should show you the change, reverting.
How long
If it
does it,
is not reverting,
how long would you start expecting the changes? Because these changes will have to reflect intracellular changes. So how
yeah.
soon?
So, that's the problem. So if you have got a ECG change in a
Mm,
clinical background where it suggests that your anti-hyperkalemic measures are only time buying measures, the
mm.
definitive treatment remains dialysis.
Okay.
If your clinical scenario says patient can re-establish the homeostasis with some support, so
Mm.
then you can recheck at 2 hours if there are ECG changes which reverts, and along with that there are no other clinical signs to push you for an emergency intervention. So you can wait after 2 to 4 hours, you recheck potassium level, and you can repeat anti-hyperkalemic measures to buy another 2 to 4 hours. If patient can achieve homeostasis, that's well and good. Then you adopt for chronic hyperkalemia management or avoiding those drugs or diet which precipitated hyperkalemia.
Okay. So one of the members in this group had asked a question to me. Patient with hypertension. Okay, now whether the hypertension is the cause or the effect, you need to be monitoring the renal function status. So what would be the frequency at which you'd want to evaluate renal function in a hypertensive patient?
Well, as per the national guidelines goes, it's once a year.
Once a year.
Yeah. But if somebody has got a CKD, whatever the reasons,
Okay.
hypertension causing CKD or CKD causing hypertension, I would go at least once in 3 months RFT with electrolytes if CKD is not very advanced. Very advanced in the sense stage 4 or stage 5.
Okay.
There I would like to see every month because I have to start the intervention and preparation for dialysis requirement or a transplant requirement. So there it will be monthly. But in the early stages of CKD, I
Yeah.
would go with 3 monthly.
3 months.
But purely hypertension, I would once in a year I will monitor.
Okay, so if there's hypertension only without much of a kidney damage, then you go once a year. If there is early
Yeah.
stages of kidney damage, then you would go once in 3 months. And as it progresses, the frequency may reduce to even once a month because that determines your interval for treatment.
Yeah.
Okay. Dr. Kinjarkar, this is a question I wanted to know about urine osmolarity. Okay, like
Yeah.
formula, instrument versus formula.
Right. Right. So, sir, we are again, fortunate to have a osmometer, and the
Privileged
thing is, sir,
people, privileged people.
so the thing is, sir, we have done both. We have done calculations and tried to correlate it with the readings on the osmometer. What we observed, sir, was in case of serum osmolarity, the correlation is most of the times good and accurate. Whereas when you come to urine, there are firstly there are quite a few different formula which are available, and you can also use calculators online. But the thing is, it often doesn't account for metabolites, which like especially if there is a lot of protein excretion, glucose excretion, lactate, and those kind of stuff being excreted in the urine. The values which are being calculated are not going to correlate well with the measured values on the osmometer. So so basically it won't be accurate. Even for serum, 90% of the times it correlates, but when there is a lactic acidosis and all, there may be an anion gap and those kind of things. It would not be. I mean, there is a chance that the calculated value is not going to be correlating well. So essentially, what the calculation uses is basically it measures the osmotically active molecules. Like in case of serum, it measures sodium, urea, glucose. Whereas when they're measuring it in urine, it may be one formula uses urea, sodium, and then another one is there which is measuring creat in their moles, in the molar concentrations. So if there is anything else which is osmotically active and is also being excreted in the urine, it is not part of the calculation. So that
Correct.
is why you're going to get a difference in the measured and calculated values, sir.
So in the serum is generally okay, correlates very well with the measured or calculated, whereas in the urine it is definitely not a good thing, right?
Yeah, absolutely, sir.
I buy that thing. Dr. Srinivas, this question is how does osmolarity, serum or urine, when do you find it in the role for your management, number one? And is it kind of a obligate thing that wherever nephrologist is, the lab should have these?
Not essentially, sir.
Okay, go on. So when do you use it? Where does it come in your algorithm of management of patients?
See, mainly if you are suspecting any issue with the kidney in concentration, then only it is of some use. Fine. So again, without a clinical history and a background, it's of no use to anyone.
Mm-hmm.
Fine.
Mm-hmm.
So maybe in a polyuria, polydipsia patients, you may require it to assess what is the status. Fine.
So
So
that you're
why it
going to the
is,
urine or the serum, what would you be interested more?
see, if serum osmolality is not required in the sense, if your sodium is normal, everything is normal, you go with the urine. If there is a sodium associated issues, then obviously you'll go with the serum. Then along with that urine, so that you know ki both values correlating or not. So the problem is it a endocrinal reason which is causing? Is a renal reason? Or is patient is perpetually drinking more water? These are the three things you want to diagnose. That's the only reason why you require them. Otherwise, the grand old test of specific gravity will take
Yeah,
you so many.
I was coming down to that. The way you're talking about it is a very glorified specific gravity. Do I understand it that way?
Practically speaking, yes.
So, a good specific gravity in a patient properly prepared for the test and not a random sample, either pre-tested by water deprivation or pre-tested with water loading. Okay, that gives you as good an information as urine osmolarity would give you. Do I understand that?
Especially if your resource constraint, first do it. Then if you are hard pressed to have a full diagnosis because that's going to change patient management, then only you can go for these tests. Otherwise, actually, a well prepared specific gravity will give you majority of the information.
And as Dr. Kinjalkar told us that the formulas are good only for serum but not good for urine, and you are wanting more of urine specific osmolarity rather than the serum. So I
If there are no
don't.
electrolyte abnormalities in serum, so what you will achieve by doing osmolality if you are worried about the polydipsia?
Okay, if the sodium in the blood is okay, you're really not bothered much about the osmolarity. That's what I get to understand, right?
Yeah. So except for SIADH, so other than that, or
SIPH again
for
can be picked up on specific gravity itself.
that's true. That's why I'm saying practically, yes, we don't require it. But yes, it's algorithm. People use formulas, validate it. Nobody dare to validate on specific gravity. That's the only thing. You and me can do it most probably.
That kind of gets me to a question. What is the value of specific gravity considering that the patients are giving random sample and you get a random value which means nothing. Unless the patient has been preconditioned, a urine specific gravity to me means nothing.
In fact, see, if somebody drinks 3 liters of water in the early morning and gives you a sample, then it's of no value to you.
More often than not, they first go to the ultrasound, have a full bladder, and then they come to the lab and give the urine for urinary. And that's the end of your specific gravity. Okay, when we are still talking about electrolytes,
So that,
huh? When we're talking about electrolytes, I mean, as a biochemist, I'm quite intrigued with this info. Why are we doing total calcium and why aren't we replacing it with ionic calcium? Assuming that we had ionic calcium to give. Not very many labs can do ionic calcium, but assuming that we had ionic calcium, would you rather want ionic calcium or total calcium? The biochemist in me tells that ionic calcium should actually correlate very well
as you
with
know,
patient.
the problem with ionic calcium is you assume every patient is normal. So still, that ionic calcium may hold good. If a person is having a disease like CKD or on medications which can alter calcium metabolism, so ionic calcium is an equilibrium state achieved by the body by using different methodologies and acid base, buffer zone and buffers and acid base, whatever the body status is. So only ionic calcium is telling me ki this is what it is. This is the status on which your calcium is so much as ionized, which is obviously the active agent for all other purpose. But what is the reserve on which so many other treatments are dependent? Like if somebody has got total calcium more, I will not be willing to supplement or put a patient on a vitamin D on a full dose, or I may not put the patient on a vitamin D at all. So many other things, like somebody is having already renal stone disease. So then without addressing the basic issue, I may not be actually able to do justice to that patient by just looking at a ICAL.
Okay, so
So
the total calcium is actually telling you what is the kind of stores available also, and ionic
yeah,
calcium just tells you what is the metabolically active form. That's what I understand. And
yeah,
many drugs would affect the total. You need to know the total calcium or the reserves.
that's true.
That's okay. Now, in acute setting, ICU patients, would there be a scope of switching over from total to ionic? Because there you want the actually metabolically active form.
Uh, if you see, majority ABG emissions gives you ICAP.
Ionic, yeah.
So if somebody has got a matlab, pH range within the normal limits and ICAL is available, I will not go for calcium unnecessarily.
Okay.
So only in the setting where ABG is not normal or it is disturbed. So now there are symptoms or signs which is telling me calcium metabolism may be hampered, is not normal. So then
Hmm.
I will go for it. Otherwise, I will not ask for a total calcium.
Okay. We are running out of time because it's already more than an hour. There are two important questions which I wanted to ask you. First question is like, what is the kind of lab support you require after a patient has gone undergone dialysis? Usually, it's a tradition to get a pre-dialysis sample and a post-dialysis sample. So, I mean, what are you actually looking for to evaluate the adequacy of dialysis?
So usually you do it a periodic way. It's
Hmm.
not a daily routine or every dialysis we don't do it until unless there's a requirement clinically which is demanding it. So in a
Hmm.
periodic way, why we do is one is monitoring of the medical management of CKD is adequate or not. That's we have to see. So
Hmm.
there's a CKD MBDS, calcium mineral metabolism in the CKD patients. We have to look into it for that. And the third part is adequacy of dialysis. Means whatever the dialysis we are delivering to patients twice a week or a thrice a week or long dialysis, is that sufficient to that given patient or no?
Hmm.
So the only parameter which matters in adequacy of dialysis is urea, pre and post dialysis.
Okay, so creatinine is not the major thing that you're looking at. You're looking more at the ureas.
Yeah.
Interesting. I was to date still looking at the pre and post creatinine and I was seeing those things. So for you, you say it and potassium, I would guess.
Yeah, obviously, because then that will decide on the patient's requirement in the sense dietary counseling, how frequently patient requires dialysis. Because you might have noticed in your experience, pre-dialysis potassiums are always in a higher zone, which may be actually in a normal population considered as an emergency.
Right.
So this is that issue needs to be addressed because as you understand, when we do potassium, majority dialysis centers do a potassium in a dialysate of 2 milliequivalent or a 3 milliequivalent.
Hmm.
Even though recommend the worldwide now everyone says do it with 3 rather than 2, but still majority uses 2. So the
Okay.
fluctuation will be too much. So at least you can titrate the dosage of the dialysis delivered to patient if you know the potassium levels, or you can counsel the patient for readjusting their dietary intake. Because
Now,
as we know, the potassium majorly coming from dietary intake.
here there's a very interesting thing which I have noticed in some of the hospitals I've worked. The pre and the post dialysis samples are sent simultaneously to the lab. Whereas I would think that the pre-dialysis sample to the lab would determine about your potassium and how to manage it, right?
It's actually not required
Not required.
because the dialysis will bring back the potassium into the range which is acceptable as a standard of care.
Irrespective of what the initial starting value was.
Yeah, if you deliver 4 hour normal dialysis to a given patient, it will
Uh,
bring back the potassium until unless there is an pathological process which is breaking down the cells and potassium is continuously raising in the body. That's a totally different scenario. In a maintenance hemodialysis patient, usually you dialyze, it will come back.
okay, then there are the other question which was very close to my heart was uh, a person has you got a good experience of lot of renal transplants you've been managing. So what would be the immediate post-transplant monitoring of the patient and what is the kind of a lab support you're expecting from us? I mean, if I were to tell my patients, here, my lab technician, these are samples you're going to get, this is what you're supposed to be doing, how do I prepare it?
So my experience is the very few important factors from the lab which is expected immediately post transplant. So other than the hemoglobin and platelet along with TLC, so I will be dependent on LDH,
Hmm.
then electrolytes and serum creatinine.
LDH,
Very few
electrolytes.
parameters.
Okay.
And yeah, because they determine majority of the pathology and the patients, whatever, if they have opened up, is it sufficient or not to sustain without a dialysis?
Okay.
So in that given scenario, my requirement is very limited because clinical input, imaging if required, and urine output. These parameters, along with these minimal lab parameters, which are reliable, are the good enough factors to decide on the patient management.
How frequency would you do electrolytes post-transplant? In the, let's say, first 2-3 days?
Usually we do once a day, at least for first 2 to 3 days, because the urine output, whenever it's a successful renal transplant, the urine produces enormous, and
Hmm.
you will be replacing volume by volume initially. Then we adjust it according to the requirements, because there's a lot of extravascular fluid which is accumulated actually also is coming out along with the urine. So as soon as they undergo transplant, so there is a lot of shift. So
Hmm.
first 2 3 days is daily. Thereafter, it depends on the clinical condition. If patient is improving, majority patients get discharged within 5 to 7 days.
Okay.
So
So that it's not that every 2 hours electrolytes, it's a 12 hours, 24 hours electrolyte. That's what I understand.
yeah,
Okay. Then what are the clues that you would be looking for to suggest early rejection? Because that is the major paranoia of a transplant.
okay. So early rejections. See again, if a given patient with a low risk and you expect the patient to perform well as per the intra-op findings or the intra-op whatever we have done, like you can see actually the kidney opening up as soon as you do the vascular anastomosis. If it is there, so that means kidney has got adequate vascular supply and it is adequately secured its position. Now urine output decides the patient is how it is behaving. If urine output improves over a period of time along with that biochemical parameters normalizing, so that telling me that you are not looking at a rejection. If urine output doesn't come out only immediately post-op without any other complications, surgical complications, or there's a vascular issue in the sense of the perfusion when you see it on a Doppler, or any clinical symptoms suggestive of a rejection, so then I am worried about rejection. So biochemical parameters help me in deciding when to intervene. So rejection is actually in the initial part is the overall clinical scenario assessment rather than purely biochemical parameters.
So the
So even though
urine
people are
output and
trying to
Doppler
get,
will help you guide it.
yeah,
And any exotic markers from the transplant immunology that you would want? I mean, whether it's a part of the standard treatment is a different issue altogether, but some things of these bubbling under.
till today, people have not delivered it. Why am I telling you this? Even in a living donor transplant,
Hmm.
the donor donates, then it goes on a ice block for a dissection and cleaning the extra tissues. That means that is a cold ischemia time. Then
Correct.
you perfuse the kidney there. Then you take it into the recipient body. So means there's a significant period the kidney is without a blood circulation.
Correct.
So as you know, whenever the tissue comes under stress, it expresses so many proteins, which
Hmm.
usually doesn't. So it's
Right.
very difficult to say which mark are going to tell you it is the expression because of the stress or it's a rejection. Because after all, it's same process in a different ways.
In liver transplant, you generally find the ASTs and ALTs shoot up immediately after transplant, and by 3 days it comes normal. That's the one that has been released because of the ischemia.
Yeah.
Okay.
See, if you understand liver transplant, the duration of transplant in liver transplant is much longer compared to kidney transplant.
Okay. Okay. Now, my questions are over. Audience questions. Audience poll right now. How do you interpret HbA1c in CKD patients? Is there any difference in the interpretation?
So it usually we tend to keep it on the higher side, first thing.
Matlab,
So if
it's from 6.5, you would go to 7, 7.5 also.
if the CKD is advanced, yes, we go up to 7.5. So,
Okay.
but in a younger lot who are just now diagnosed to have a renal involvement in because of the diabetes,
Hmm.
so then we will go for a strict control. So we'll try to achieve the HbA1c target because the risk of hypoglycemia in the early stages of CKD is almost as normal as any other normal population.
There was a question about serum creatinine to be expressed in 1 decimal or 2 decimal points. Does it really make a difference?
It depends on the lab variation.
No, lab variation, let's take it out. Like that is total our domain. We'll work
Ah,
onto that separately. But
if it
assuming
is
that the
in an
reports we give you are authentic, valid, reliable, we when we sign a report, by default, all these are come into it. So some people have been
yeah.
insisting on 2 point report, 2 point decimal, 2 decimal point reports.
So with the modern definition of AK, it matters. Just giving you example, 1.21
Hmm.
and 1.49. So not an AKI. 1.21 to 1.53 is a AKI. So now somebody is 1.25, 1.55 is
Okay.
the borderline. So now if you don't give me the second decimal, I will not be able to tell you it's an AKI or no
Okay.
by
So we take
definition.
it. We take it. All of us look at 2 decimal points for reporting. Very good. Post dialysis, you said you're looking at the urine or the urea to evaluate the kind of response. Is it immediately after the dialysis is over when you're closing the anastomosis, or do you take it 2 hours afterwards?
So usually we do at this when you start the dialysis, that's the
Hmm.
starting sample, that's a pre-dialysis sample.
Correct.
So second sample is taken before you just close the dialysis.
When you must be putting a heparin kind of a plug to prevent the clots and all that stuff, right?
Yeah, that is you don't use heparin in the last 1 hour of the dialysis.
Okay, you don't use heparin
So
the last 1 hour of the dialysis. Okay. I was
yeah,
intrigued. When do they put the
and
heparin and how does it impact the sample collection?
so the first sample is without any heparin that you know now.
Correct.
The second sample will have minimal heparin in it if they are given a dialysis with heparin.
Okay.
So usually anywhere between 3 to 5,000 units of heparin you are using. Fine. So you stop it at third hour. So you are taking it fourth hour plus means more than the 75% of the heparin you are given is already washed off.
Okay. And the remaining heparin may not significantly alter biochemical parameters. I get that.
Correct. Yeah.
Okay. What is the purpose of estimating serum ferritin in CKD patients? Is it a marker of iron stores or inflammation?
So the problem with CKD patient, as you know, ki iron deficiency.
Right.
So as on date, the recommendation goes if the ferritin levels are higher, you are not supposed to supplement them with IV iron
Okay.
because it's not going to help in improving the hemoglobin, but it can actually trigger a lot of inflammation wherever it is. Fine.
Okay.
So, and obviously ferritin being used as an inflammatory marker in different definition in a different way. Fine. If in a patient, given patient, ferritin is low, is tell you ki at least the chronic inflammation status is well under control. If ferritin is high,
Hmm.
so obviously telling some pathology is troubling the patient. It may not be CKD per se. There may be many other reasons because so many patients have vascular access issues. Somebody will be on a catheter. Somebody will have a secondary infection, maybe in lung. So many things. So we don't know. So those things to be kept in mind while analyzing the ferritin report, not purely on a basis of data.
So this ferritin report is a part of your routine investigation, or you would ask it in specific situations, or how does it go?
Usually we ask it as a part of iron profile rather than specifically asking for ferritin in a
And
maintenance hemodialysis unit.
okay.
So it's not actually the part of the inflammation assessment protocol, it's the part of the iron store assessment protocol.
Okay. Dr. Kinjalkar, you got any questions to ask Dr. Srinivas? We really bugged him quite a bit now, but still, I'll give you the last chance. I've asked the audience poll questions.
No, I think I mean, it's been a very long session, sir, and most of the questions have already been answered. I just wanted to share one thing, especially related to, I mean, these are probably related to artifacts what one should be aware of. When we look at, say, hyponatremia and all in our lab, so the osmolarity sometimes helps because, especially ours being a cancer hospital, we get a lot of paraproteins and those kind of stuff. And to differentiate a true hyponatremia from a pseudo hyponatremia, checking osmolarity often helps us in identifying these kind of things. And medications, like sir said, we have seen patients with hypokalemia who have been on hypokalemia at the level of 2 1.9 potassium levels, serum potassium, for over a month, and they have been on amphotericin. Liposomal amphotericin is going on and they are hypokalemic. So, like sir said, the clinical picture is very important, and we should we should consider everything in totality and not just the lab values. So, I know I am privileged because I have access to that information in my setup.
Don't rub it to everyone.
No, no. So, what I mean to say is you should try and extract that information, sir. That's all I want to say.
Great, guys. Thank you very much. Thanks a lot. A lot of interesting points, a lot of interesting discussions, a lot of clarity from my side about what the nephrologists are doing with my reports and what they're actually reporting and expecting. Dr. Srinivas, thank you very much for joining us. Dr. Kinjalkar, I really appreciate fielding all the
Thank,
biochemistry questions. Otherwise, I would have had to read a lot about it. Thank you very much, partners. Till we meet again.
yeah,
Thanks.
thank you.
Thank you, sir.
Thank
Thank you.
you. Good
It
night.
was really a
Thank you.
pleasure talking to you. And we hope to have you back very soon.